Hi Sam, my name's Dane. I'm going to be your nurse today, and I'm going to be conducting a head-to-toe assessment on you today for your general wellness. Okay?
Alright.
Alright, I'm just going to put some hand sanitizer on and get some gloves on, and we'll get ready to go. Okay?
Awesome.
And we got your medical history already, and that's all in the system, so you don't have to worry about updating that right now, okay?
Awesome. Thank you.
Yeah? Okay. So to start with the assessment, I'm going to begin by inspecting the patient's head. I'm looking for symmetry. I'm looking for any signs of acute trauma, inspecting the quality of the skin, the coloration. I'm looking for any type of masses, lacerations, or anything like that. After inspection, I'm also looking at the quality of the hair, dispersion, texture, as well as the consistency of it. Everything looks to be normal. I am now going to palpate the skull, working from front to back. Once again, looking for any masses, nodules, depressions. Is there any tenderness, Sam, when I
No.
palpate your skull? No. Okay, good. Excellent. And can you just open your mouth for me? Any pain along the jaw?
No.
Okay. I'm going to have you pull your mask down briefly while I assess the rest of your face, looking at symmetry of the nose, the mouth, the lips, as well as the eyes. Excellent. So Sam, the first thing we're going to assess is sensation on the face, okay? So I have a Q-tip here, and this is going to be soft, and this is going to be sharp.
Okay.
Okay? So I'm going to have you close your eyes, and I'm going to either put the soft or the sharp on your face, and I'd like you to tell me where I'm placing it and if it's sharp or soft, okay?
Alright. Soft on my left cheek.
Okay,
Sharp on my forehead.
excellent.
Soft on my right cheek.
Excellent. Okay, I'm also, since I'm doing sensation, I'm also going to assess the rest of the sensation on your body.
Okay.
So we're going to do the same thing, it's just going to be on other parts of your body, okay?
Awesome.
So close your eyes.
Soft on my left shoulder.
Okay,
Sharp on my right hand.
okay,
Soft on my left knee.
okay.
Sharp on my right knee.
Excellent. Okay. So now that I've done sensation, I'm now going to assess your cranial nerve function in your face. So if I can have you open your mouth for me. Okay. Bite down, clench your jaw, smile. Excellent. Raise your eyebrows, frown. Okay. And then puff out your cheeks. Excellent. And now close your eyes as tight as you can and don't let me open them. Perfect. Okay. After assessing the cranial nerve function as well as the sensation in the face, I am now going to begin inspecting the patient's ocular region. So I'm looking at the quality of the brow, I'm looking at the eyelids, the quality of the conjunctiva, no acute inflammation present or irritation, as well as the quality of the sclera and the eyelids themselves. And I don't see any signs of irritation, swelling, or ocular discharge by the lacrimal glands, which is awesome. Okay. So Sam, we're going to do a couple tests now to assess your vision, okay?
Okay.
So over on this wall there's a Snellen chart, and I would like you to cover one eye and read the lowest line that you can.
P Q R Z S.
Excellent. And can you cover the other eye and do the exact same thing?
Z Y A D.
Excellent. So the patient displayed 20/20 vision, which means that he is able to see what a normal person can see at 20 feet away. So you have good vision. Excellent. So then, now I'm going to assess your visual fields. Okay, so I'm going to be looking at peripheral vision. Okay.
Okay.
So I'm going to have you cover one eye for me, and then I'm going to hold up fingers. How many fingers can you see?
2.
Okay. And now can we do the other eye? Cover you up.
3.
Okay. Excellent. So visual fields are intact. Finally, Sam, I'm going to test your visual tracking, okay, using the cardinal visual fields. And what I'm going to have you do is I'm going to have you follow this light, okay?
Okay.
And don't move it with your head, just follow with your eyes,
Okay.
okay? Okay. Excellent. No nystagmus is noted, and the patient is able to track. Okay, I think we're still going. And the patient is able to track with no nystagmus present. Very fluent tracking with his eyes. Okay. And finally, Sam, I'm also going to assess accommodation. So I'm going to have you follow this light.
Okay.
And I'm going to bring it close. Excellent, and away. And accommodation is present with both eyes tracking adequately and also constricting at the nearest point. Finally, Sam, I'm going to assess your pupillary reflex. Okay. So I'm going to briefly shine this in your eye. Excellent. Another eye. Okay, and both pupils constrict accordingly. Okay, Sam. The next assessment, I'm actually going to be looking into your eye and visualizing some of the internal structures of your eye.
Okay.
Okay? So I'm just going to have you hold still for me, and I'm going to take a look inside your eye, making sure to use my pinky to stabilize the otoscope. Upon inspection, I am able to see the retinal vasculature as well as the optic cup, and the red reflex is present. And Sam, can you look directly into the light for me? And I'm able to see the macula and the fovea. Okay, and I'm going to do it on the other eye, Sam. Okay.
Okay.
The retinal vasculature is intact, no sign of hemorrhage present. The red reflex is present, as well as, can you look straight into the light, Sam? The macula is present, as well as the optic cup. Okay. So next thing, I'm going to assess your nose. I'm looking for symmetry in the patient's nose, with no signs of inflammation. Does this hurt, Sam, when I palpate your nose at all?
No.
Okay, so the nasal septum appears midline. There is no acute trauma present on the nose, as well as no acute inflammation on the outside of the nose, with no tenderness noted during palpation. Sam, I'm going to have you tilt your head up real quick, and I'm going to take a look at the inside of your nose. Okay. Turbinates are present. There is no acute inflammation present. The oral mucosa is light pink, and the membranes appear to be moist with good hydration. Okay, Sam. Now I'm going to take a look in your mouth, okay? So I'm going to have you open up. Okay, inspecting the quality of the dentition, looking at the coloration of the oral mucosa. Good hydration present. There is no lesions or scarring or any type of abnormalities on the tongue, which is nice and pink in coloration. And Sam, can you say ah for me? Okay, and the uvula is midline. Excellent. After assessing the patient's oral cavity, I'm now going to inspect the patient's ears. So Sam, I'm going to briefly inspect. I'm looking for any type of irritation, redness, as well as the presence of any discharge from the external canal, which I see none. Is there any tenderness, Sam, when I palpate along the external ear?
No.
Okay. And a good rule of thumb, if there is some sort of tenderness present during palpation, it could be a sign of external otitis infection or an otitis media infection. Okay. So Sam, I'm going to do a couple hearing tests now before we take a look at your ophthalmic scope. Okay.
Okay.
So what I'm going to do is I'm going to walk behind you. I'm going to cover one ear, and I'm going to whisper something into your other ear, and you're going to repeat it for me, okay?
Okay.
Okay.
Marquette.
Excellent. Nursing.
Nursing.
Okay. And we're going to do a couple more tests. So this is a tuning fork, and what I'm going to do is I'm going to tap it. I'm going to place it on your forehead, and I want you to tell me what side, or if it's one side versus if you can hear it equally throughout your ears, okay?
Okay.
Okay.
I hear pretty equally.
Equally? Excellent. Okay, and now we're going to do one more test called the rim test. So So what I'm going to do is I'm going to hit the tuning fork. I don't want you to tell me when you no longer feel it.
Okay.
Okay?
No.
Okay. Can you hear it?
Yes.
Okay. So air conduction is greater than bone conduction on the right side. Let's try it one more time on this side.
No. Yes, I can still hear it.
Okay. So air conduction is greater than bone conduction on both sides, which is a normal finding. And finally, Sam, I'm going to be inspecting your inner ear, looking at your tympanic membranes.
Okay.
So let me put a sleeve on this. Okay. I'm going to pull the patient's ear back. And the tympanic membrane is pearly gray in color with a cone of light facing the anterior portion with no erythema or bulging present. I'm going to do it on the other side, Sam, ensuring to pull the patient's ear back. Once again, the tympanic membrane is pearly gray in coloration with a cone of light facing towards the patient's jaw with no signs of bulging, redness, or irritation. Okay. So Sam, after I've assessed those, I'm now going to take a look at your neck. Okay.
Okay.
So I'm going to have you pull your mask down real quick. Excellent. And what I'm looking for now is I'm inspecting the patient's throat. I'm specifically looking at the patient's trachea, seeing if it's midline. If there's any sort of deviation from the trachea, it could indicate some sort of pulmonary complication. So the patient's trachea appears to be midline. I'm going to briefly palpate your throat, Sam.
Okay.
Is there any tenderness?
No.
Excellent. I'm going to briefly have you take a swig of this water. Keep it in your mouth. Okay. And I'm going to palpate for the thyroid real quick. Okay, Sam, you can swallow. Okay. The thyroid was non-palpable, which is a normal finding. Okay, Sam, now I'm going to be taking a look at your lymph nodes. Okay.
Okay.
So I'm going to be palpating. The preauricular. Postauricular. Occipital. Tonsillar. Submandible. Submental. Pre and posterior cervical. As well as supraclavicular. And no lymph nodes were palpable during this time, which is a normal finding. Sam, I'm going to have you lift your shoulders up against my resistance. Excellent. So that means the cranial nerve 11, the accessory muscle cranial nerve, is intact. And I'm also going to assess the range of motion of your neck, Sam.
Okay.
So can I have you turn your head this way? Excellent. Can I have you turn your head the other way? And then back. And then forward. Excellent. And I'm going to have you turn your head this way into my hand against resistance. Can you turn your face? Excellent. And then the other way. Excellent. Perfect. Okay. From there, I'm going to be inspecting the patient's posterior chest. So we're going to first inspect from behind. I'm looking for the spine to be midline. I'm looking for any acute distress, any type of asymmetry during inspiration or expiration, as well as any masses, notable tenderness, or anything like that that could be causing acute trauma for the patient. And there are no abnormal findings via inspection. Next, I am going to palpate. So I'm palpating down the patient's spine. And Sam, if you feel any tenderness during palpation, just let me know, okay?
Okay.
Any tenderness?
No.
Okay, excellent. Next, I'm going to percuss the posterior chest, listening for the resonance. Percussion over the lung fields should result in tympanic repercussions, so that would be considered a normal finding. So, And percussion is consistent tympanic throughout all lung fields, which is an expected finding. Did you have any tenderness during percussion, Sam?
No.
No? Okay, excellent. So before I listen to your lungs, Sam, I'm going to place my hands down on your lower back, and can you take a nice deep breath for me? Okay, excellent. So both thumbs spread about 2 to 3 centimeters, and they were parallel, and they expanded bilaterally equally. So that is a normal finding. And one more thing, Sam, I'm going to assess you for CVA tenderness, which could indicate renal complications.
Okay.
So let me know if you have any tenderness during this. Do you have any tenderness during that?
No.
Okay. Next, we're going to auscultate the posterior chest. And before doing so, I'm just going to clean off my stethoscope, the alcohol prep pad. Okay. So Sam, whenever I place my stethoscope on you, I'm going to have you take a nice deep breath through your mouth, and you can let it back out through your mouth. Okay? Okay, here we go. Excellent. Okay. And breath sounds bilaterally are clear on auscultation with no crackles, rhonchi, stridor, or any acute respiratory distress noted during auscultation. Okay, Sam, and one last thing I'm going to do on your back is I'm going to listen for tactile fremitus. So every time I place my hand on you, I would like you to say the word 99.
Okay.
Okay, so here we go.
99. 99. 99. 99. 99. 99.
Okay, excellent. Now I'm going to begin inspecting the posterior chest, the anterior chest of the patient. Once again, I'm looking for symmetry of expansion and work of breathing, as well as any type of asymmetry or acute distress on the anterior side. And none is noted. So Sam, I'm going to do the same thing. I'm going to briefly inspect, and now I'm going to palpate, okay?
Okay.
Can you let me know if you have any tenderness, okay? So during palpation is a great time to feel for any thrills, heaves, or lifts, and also a good time to palpate the point of maximal impulse, which is midclavicular fifth costal space. And the PMI is felt and has a nice strong pulse. Okay, so now I'm going to do some percussion on your chest, okay? Once again, assessing and percussion reveals tympanic resonance throughout lung fields, which is an expected finding. Okay. Now, Sam, I'm going to take a listen to your heart and your lungs again, okay?
Okay.
So same thing, I'm going to have you take nice deep breaths whenever I place the stethoscope on you, okay?
Okay.
Okay. And 2 more. Excellent. So lung sounds, once again, are clear bilaterally with no diminishment, crackles, rhonchi, or any stridor noted during inspiration or expiration. So Sam, now I'm going to take a listen to your heart, okay?
Okay.
Okay. Pulmonic, tricuspid, and then mitral. And then I'm going to repeat the same procedure with the bell on my stethoscope, starting with the aortic, pulmonic, tricuspid, and mitral. And heart rate is normal, with normal rate rhythm, with no murmurs, gallops, or rubs detected during auscultation, which are all normal findings. Okay. And one more thing, Sam, I'm going to take a listen to your carotid artery in your neck, okay? Using the bell on my stethoscope. Nope, you can keep your mask on, that's okay.
Okay.
And I'm also inspecting during this time for any type of jugular venous distension, which there is none present. Excellent. No bruise associated with the carotid artery. Okay, Sam. So I'm going to have you take a seat back for me, okay? Is that comfortable for you there?
Yes.
Okay. So one more time, I'm going to listen to your heart when you're laying flat. Pulmonic. Tricuspid. And mitral. Repeating with the bell. Okay. Okay, Sam. So now I'm going to take an inspection of your abdomen. Okay.
Okay.
So for your abdomen, I'm going to start off by inspecting the shape of it. I'm looking at the contour of the abdomen. For any abdominal masses, distension, discomfort in the patient. Are you having any abdominal discomfort right now, Sam?
No.
Okay, excellent. So after inspection of the abdominal wall and the abdominal cavity, I am going to auscultate all quadrants of the abdomen before palpating, percussing, or performing deep palpation to assess the liver. And patient has bowel sounds and normal active bowel sounds in all four quadrants. So after that, I'm going to briefly listen to the patient's abdominal aortic artery, his renal arteries, his iliac artery, as well as his femoral arteries with the bell of the stethoscope. Okay. And no bruise were detected during auscultation, as well as no pulsatile masses on the abdomen, which would be an indicator of a abdominal aortic aneurysm. Okay, Sam. Now that I've done that, I'm going to briefly lightly palpate on your abdomen, and let me know if you have any discomfort. Okay. Any tenderness?
No.
Okay. So after light palpation, I'm now going to do percussion to assess the border of the liver, as well as along the abdomen to see if there's any type of consolidation or fluid buildup in the cavity. And what I'm listening for is when it changes from dull to tympanic because of the gas and hollowness of the abdominal cavity. So I'm able to approximate the liver. And I'm going to do a little bit more deeper palpation to see if I can actually feel your liver as well as your spleen, okay?
Okay.
So I'm using my first hand to feel and my second hand to guide in with a circular motion. You let me know if you have any discomfort, okay?
Okay.
Palpating for the spleen, as well as the liver. And we're going to briefly try to attempt to palpate the liver via the hook method underneath the patient's rib cage. And the liver is non-palpable, as well as the spleen, which is a normal finding. Okay, Sam. Looks good. Okay. So from there, I'm going to assess now the patient's upper extremities and lower extremities, muscular function, as well as neurological function. So Sam, I'm going to have you sit back up now. Excellent. So to begin, I'm going to inspect the patient's upper extremities. I'm inspecting the shoulders, the biceps, the triceps, the elbow joint, the wrists, as well as the fingers. The length and size of both upper extremities appear to be bilateral, as well bilateral in length and size, which is a normal finding. And now Sam, I'm going to briefly palpate, okay? Can you let me know if you have any tenderness?
Okay.
Palpating the shoulders. Any tenderness, Sam?
No.
Okay. Palpating the biceps, and the triceps. Any tenderness, Sam?
No.
Okay. The forearms. Okay. Other shoulder. And during palpation, I'm not noting any masses or tenderness via objective response from the patient. Okay. After inspection and palpation of the upper extremities, I'm going to do active range of motion, Sam. So we're going to assess your ability, the range of motion in your shoulders, okay?
Okay.
So can I have you raise your arms over your head and bring them together like this? Excellent. Bring it back down for me. After assessing the shoulder range of motion, I'm going to assess the bicep and the tricep extension and flexion. Sam, can you just bring your arms up for me and then extend them out? Okay. And then rotate. Perfect. And then bring your hands up, down, then side to side. Rotate for me. Perfect. And then wiggle your fingers. Perfect. So now, Sam, I'm going to assess the strength in your upper extremities. Okay. So I'm going to have you hold your arms up for me, and I'm going to try to push them down. Don't let me push them down. Okay. Okay. And there is no give in the patient's deltoid or shoulder strength. Sam, I'm going to have you bring your arms in like this, and I'm going to try to pull them out. Don't let me pull them out. Okay.
Okay.
Patient demonstrates 5 out of 5 bicep strength. Sam, I'm going to have you do the same thing and now push up. Perfect. Extensor function and extensor strength is intact. 5 out of 5 response. I'm also going to have you push up into my hands. Excellent. And squeeze. Give my fingers a squeeze. Bilateral strength in the hands and the grasping strength. So 5 out of 5. Excellent. Perfect. And now I'm going to assess your reflexes, Sam.
Okay.
Okay. So I'm going to be doing 2 reflexes in the upper extremity, specifically the bicep reflex and the tricep reflex. Okay. So to begin, I'm going to feel for your bicep tendon. Okay. And you can just relax your arm right there. That's perfect. And what I'm looking for is a brief contraction of the bicep. Excellent. One more time. Okay, and now for the tricep, I'm going to raise the patient's arm up. You can bend it for me and just relax. Just relax it. Okay. I'm going to be palpating for the tricep. And it's right there. I'm looking for extension. One more time. And there it is. I'm going to do the same thing on the other side now, assessing the bicep first. Okay. There it is, as well as the tricep. Okay. From there, I am now going to assess the lower extremities. But before I do that, I'm going to briefly check the patient's pulses in the radial portion bilaterally. And they are symmetrical, as well as the patient's capillary refill time. And the capillary refill time is under 2 seconds, with radial pulses being 2+, which are all normal findings. Okay, Sam, so now I'm going to be inspecting your lower extremities, okay?
Okay.
So to begin, I'm looking for symmetry in size, as well as in length, which can indicate any type of hip dysplasia or anything like that, and I don't notice any differences symmetrically. I'm also inspecting for any masses, discoloration along the legs, which could indicate venous diseases or clotting disorders. Any discomfort, Sam,
No.
when I palpate on your legs? Okay. Excellent. I'm gonna palpate down below. Under the thigh. Any discomfort, Sam?
No.
Okay. Excellent. So after inspection and palpation, there is no acute distress in the patient's lower extremities. So Sam, once again, I'm going to be assessing some range of motion on you. Okay. So can I have you just lift your hip up like that? Perfect. And bring it down for me. Lift your other hip up. Excellent. And can you straighten your leg out for me? Perfect. Rotate your ankles. Excellent. And then can you do that with the other leg? Straighten it out. Rotate the ankles. Perfect. And then I'm going to have you lift your feet up like that. And then push them down on the gas pedal. Perfect. So range of motion has been assessed, and patient has full range, active range of motion in all joints of his lower extremities. Sam, I'm going to be assessing some of the strength now in your lower extremities. So what I'm going to have you do is I'm going to have you lift your leg up like we did, and don't let me push it down. Okay? Okay. And the other side. Perfect. And I'm going to have you extend your legs out, and don't let me push them down. Perfect. One more thing, I'm going to have you keep your legs tucked in like this at the bed, and don't let me pull them away from the bed, okay?
Okay.
Okay. So those just assess the patient's quadriceps, as well as their hamstrings and glutes, as well as his hips. I'm also going to assess the plantar flexion and dorsiflexion strength. So Sam, I'm going to have you bring your foot up, okay? And I'm going to have you push your foot down. Excellent. Same thing on this side. Excellent, and down. Okay, and now I'm going to briefly assess the tibial pulse as well as the pedal pulse. Okay, as well as the pedal. And both pulses are present, 2+ bilaterally. And I'm going to briefly assess the popliteal. Once again, 2+ bilaterally. And then I'm going to assess the reflexes in your legs, okay?
Okay.
So what I'm going to do is I'm going to assess the patellar reflex, and then I'm going to do the Achilles reflex. Okay? So I'm looking for the site, just right there. Okay. And on this line, right here. Excellent. Patient has strong reflex at the patellar tendon. Now I'm going to assess Achilles. Okay. Okay. And the patient had strong Achilles reflex as well. If there was no reflex present, it could indicate Achilles damage to the tendon or other types of Achilles wear. Excellent, Sam. So now, Sam, now that we've done your sensation and everything like that, I am going to, one more time, assess your sensation of vibration. Okay? So it's going to be kind of like the same with the sharp and the soft. I'm going to have you close your eyes. I'm going to place this on you, and I want you to tell me when you don't feel it anymore. Okay? And where you feel it.
Left forearm, and stop feeling it then.
Okay.
Right thigh. Stop feeling now.
Okay.
Left shin. Stop feeling now.
Okay. And patient's sensation of vibration, as well as sharp versus soft, is intact bilaterally in both upper, lower, and facial regions. Perfect. So Sam, now we're going to do some cerebellar tests, just to test how good your cerebellum is and if it's functioning correctly, okay?
Okay.
So the first thing I'm going to have you do is rapid alternating movement. So I'm going to leave your hands on your lap, and it's going to go like this. As fast as you can. Perfect. Next thing I'm going to have you do, Sam, is I'm going to have you trace your shin with your other foot. So it's going to be like this. And then bring it back up.
Okay.
So trace your shin for me. Perfect. And then can you do it on the other side? Excellent. Okay. And then the last thing we're going to do, Sam, is we're going to do for your cerebral functioning is I'm going to have you reach out and touch my finger, and then go back and touch your nose, and then my finger, and your nose. And now I'm going to have you close your eyes and do it the same thing. Finger, nose. One more time. Finger, nose. Okay. Excellent. And the last thing I'm going to have you do, Sam, is I'm going to have you stand up, and we're going to assess your gait as well as one more cerebral function. So I'm going to do the Romberg test. So I'm going to have you stand with your feet together. You can lift your arms out and then close your eyes for me. And I'm looking for any type of sway or instability in the patient, which there is none. Okay, Sam, you can open your eyes for me. So now what we're going to have you do is I'm going to have you walk just normally. And I'm assessing the patient's walk, looking for head, heel to toe walking with opposite arm swing, which is present. And I'm going to have you walk back that way, Sam. Perfect. And I'm just going to have you walk toward this wall now. And instead of doing normal, I'd like you to walk on your toes. Just your toes. Perfect. And I'm going to have you come back. Perfect. And then one more time, and I'm going to have you do it on your heels now.
Okay.
Excellent. And I'm going to have you come back. Perfect. And I'll have you have a seat on the bed, Sam. And that concludes our head to toe assessment. Thank you.
Thank you.